So the loose brief from Forch was just talk about some tips and tricks. So I thought I'd quickly talk about kind of how I explain to people what a concussion is, because I know from some of my workshops that I teach that can be quite tricky for people. And then I'm going to rattle through a couple of cases. I have to say my slides aren't as pretty as Dane's, so I preemptively apologize. So as far as
get your kids to run in the game, isn't it?
Yeah, give you a small naked child's butt to just if anyone was half asleep. Cool. So we've kind of moved on from this, bowl of jelly that gets shaken into the sides of the box analogy. That is what certainly I understood of concussion probably when I first got into this more neurophysiological model. So to take us all hark back to neuro at undergraduate level, we understand about the structure of a neuron there, and we've got these ion channels. So normally, this action potential gets moved along the ion channel by ions moving along the axon, by ions moving in and out, getting that depolarizing happening. But when we have a concussion, when this impact is transmitted through the brain, basically, if we still think of that jelly, it's more about the jelly actually warping. And so each individual fiber gets kind of a tweak. And so some of those channels get opened and some of them get closed. And we basically just get this massive influx of ions in and out of the cell and lots of aberrant firing. So I use that sprinkler analogy a fair bit to patients. And essentially what that works out to be like is a fireworks display. So they burn up all the fuel at once. And then we have this period of time where your brain is in a bit of deficit. The easiest way to understand it is glucose as far as the fuel, but there's a few more other, where you have a deficit for glutamate, calcium, potassium, all sorts of things. But we have this period of time where the brain wants lots of fuel, the demand's gone up, but actually the cerebral blood flow goes down. So it's a bit of a mismatch. And that's often why people have that crash straight away. And then slowly, as those levels start to recover a little bit, they recover some of their functioning. But typically it's this fuel hungry kind of inefficient brain scenario that drives a lot of the symptoms that we're experiencing. So sprinkler and fireworks is probably my two analogies for that one. Everyone knows I love an analogy. If we shift gears a little bit and just talk about a bit of a Nikki case, this guy did have a history of concussion, but you could apply some of what we're going to talk about to any of your Nikki patients that you're seeing on telehealth. So this guy had an injury 3 years ago and he's got ongoing symptoms, so persistent post-concussion symptoms. And when I was first chatting to him, he said, I've got headaches everywhere. It's all over the place, all over. And it was quite hard to kind of pin him down to what's going on. Without getting too deep into it, he has been fully unfit for work on ACC for the last 3 years. He's run the gamut of every different person you can see for various types of intervention. And he's kind of been labeled with this hypersensitivity diagnosis. So I guess the key thing with telehealth is actually sort of trying to pin down, like, you've got a bit more time, I feel like, to listen to them. So I really tried to get a bit of a deeper headache history out of them. I said, well, what are these headaches? When do they come on? What makes them worse? What makes them better? And there was a bit of a pattern that sort of started to come out. And one key thing that he mentioned was he had decided he was going to go off to the gym, and he'd done a whole lot of quite heavy shoulder press and some overhead things, and found that all of his headaches were a lot worse, but particularly this one he described that started on the left side, kind of from the back of his neck and radiated up. And then he also described this quite different sort of tension type tight band across the front of his head that those of you who've worked with these kind of people will have heard about a million times. There's nothing he was describing in his history or anything going on medically that made me think about any significant red flags. So I thought, well, this might be a bit interesting to have a little bit of a look at what's going on with his neck. And he was a really good advertisement for this. So when I did, those of you who didn't study at AUT, this is a movement diagram. So the blue means that his movement was restricted by resistance, basically. That's just where he got to. Whereas if you see a red line, it means that that was sore, provoked his pain. So when I just got him to do the movements that you see there, so work through his rotation and flexion and things, he was all right. He was a little bit kind of stiffer moving to his left, but it didn't provoke any pain. And in range flexion, he described this kind of pull between his shoulder blades, but there wasn't really much that came out of that. Whereas when we got a little bit more specific, this is what happened. So when we're thinking cervicogenic headache, or a potential symptom driver being in the neck and being associated with headache symptoms, it's coming from the top 3 levels of the neck. Okay, and so we have to think about trying to isolate our range of motion assessment a little bit more down to those levels. So when the head comes into flexion, the occiput slides in a posterior direction. Okay, and so we're talking about AO flexion. So the way we sort of differentiate that a little bit is the old interlock your fingers and then get them to do just a little craniocervical flexion and extension, but in a little bit more of an isolated fashion. And the minute he did that, he was like, right, well, yep, don't like that much. Okay, so the flexion brought on his pain. And then when we think of rotation, he also reported that when he was trying to rotate, so what I'm talking about here is the flexion rotation test, which looks a little bit more specifically at C1, C2, where you, this is going to squash my microphone, but you put them down into full flexion and then you ask them to rotate. Okay. The difficulty with Telehealth is you're relying on that being an active flexion rotation test, which isn't as sensitive as the passive one. So normally if we had them in our on a plinth, you'd put them in supine, you'd fully flex them, and then you'd have a look at the rotation. But for him with that was quite restricted to that right side, okay? But his side bend was restricted to the left. So if we think of that AO trying to slide back when he's coming into flexion, when we're rotating at C1, C2, we also get a bit of a coupled motion happening there. And so he had this quite consistent pattern of some things not being particularly happy when they're being moved. So that was cool. The other thing you want to think about with telehealth, and this is a bit tricky, you have to be a bit creative with it, is how we differentiate between pain that's being driven by an active structure as opposed to a passive structure. So we're kind of talking muscle versus joint here, joint capsule, you know, something along those lines. It's pretty hard to get them to do a fully passive movement, obviously, but you can get it going a wee bit. So typically for, if I'm looking at craniocervical flexion, I get them to kind of hold their jaw and the top of their head, and you can play along with this if you like at home. But if you actually initiate that nod from particularly your top hand pulling forward, you can actually do it reasonably passively. And in that same position, you can provide a little bit of resistance with each movement. So you're trying to differentiate. Obviously, if there's more pain when you're trying to resist a movement, we're thinking it's more likely to be the active structures. Okay, if there's pain with passive but not active, we're thinking it's more likely to potentially be some of those joint-based structures. So there's a few things like that we can play around with. Forch is just choking himself in the background there. And this is quite interesting. So this was a study, this Bogduk 2009 paper is quite fascinating if you're interested in cervicogenic headache. There's a whole lot of detail in it. But basically, in this particular study, they injected saline into the back of people's necks at different levels and looked where the pain was provoked. So these were people asymptomatic normals. And if we look at the distribution, particularly at sort of 0 to C1 and C1 to C2, where the pain distribution was, it's pretty bang on where our chap was feeling his pain. So we can start to see some links in the scenario happening there. As far as what you can do with them, the nice thing if you have a look at the clinical practice guidelines is that with chronic neck pain, you can try a whole lot of different things. Okay, there's level B evidence for a variety of different options, which can include mobilization and manipulation. Bit tricky at the moment. What I did with him was taught him some self snags. I also gave him some of those segmentally isolated assessments as a self mode, particularly that flexion one, because interestingly, as he did a few of them, he said, oh, actually that feels a bit better. You know, he sort of got it moving a wee bit. I don't like to talk about postural retraining because the research is questionable about whether there's a link between your posture and pain. But movement variation, I think, is really important, and particularly at the moment, if we're all sitting around probably more than we normally would be. It's that idea of get up and move, go do something different, sit differently, put your screen at a different height, those kind of things. He was also going to do some soft tissue release. You can get the peanut balls, or a cheaper version I tell people is to just put 2 tennis balls in a sock and tie a knot in the end, and you can lie on that in supine and roll around on it, and often you can get some quite nice sort of neurophysiological release from some of those tight points you get in the back of the neck. And then I started him on some deep neck flexor retraining. Not because I could assess that properly, because that's difficult. We can't use biofeedback in this kind of situation, but I did talk to him about what it felt like when he tried to activate his deep cervical neck flexors. So that's where we're initiating that craniocervical flexion. And he described a very strong sensation of tightness in the back of his throat. And that's something that you quite often get when some of the muscles that are attaching onto the hyoid are trying to work really hard. And you could actually see, even in this medium, that this chap had really big developed sternocleidomastoid bellies. And we know from the literature that chronic headache, there are changes in the patterning between those muscle groups. And so I thought, well, there's not a lot of harm in having a go at that. The other key thing with this guy is that, he hadn't tried this stuff before. And so often if you give people, and this is the argument against specificity of retraining or whatever, but actually I think sometimes people just love a plan and they love having steps that they can take themselves. And that's where I feel like telehealth can be a boon in some ways for us as therapists, because you can't rely on your hands. Now, I know if this guy had come and seen me in the clinic, I probably would have just done lots of hands-on stuff and then finished off with a quick chat about some things he could do in his own time at the end. Whereas this way, the focus shifts completely in the opposite direction. And it's all about those self-reliant strategies. So yeah, that was that chap. The second one, I could think of a million different people we could discuss here, but this is a common question I get from physios who come and spend time with me in clinic, or who send patients to me, or who've come to my workshops, is that athlete you have after a concussion and they've got to the point where they're feeling pretty good and they're looking at returning to training. They've gone through that graduated return to play, they've got through aerobic stuff pretty happily, and they get into sort of team-based training and they get a massive symptom flare and they have to dial it back. And I just want to put this out here as a kind of something to think about, sort of a framework for how you can break that down a little bit more, because this is what I do basically, is just have a think about that athlete and what do they specifically need, and which of those parameters are we going to change within a session. Because if we think about someone who's been sitting on the couch for a couple of weeks because they've just been told to rest, and then they've come to Axis, had some excellent advice around active rehab, got back into things, and then we're looking at putting them back into a team sport training environment. That's a big spike in load and on a whole lot of levels, whether it's autonomic function as far as the exertional responses with the change in intensity. They might be doing lots of change in direction and agility based stuff. There might potentially be some strength, explosive power components. If we think of a netball player who's suddenly doing jumping and landing and those kind of acceleration tasks. And then it's the cognitive side of things that sometimes I think we underappreciate. So I had a really good chat with a chap just last week who he plays professional rugby. He's been out for a little while and he's been working his way through this process, and he'd had a little bit of a symptom spike after a particular training session. And I said, well, what were you doing? And he said, oh, we're talking about line outs. And that's not something that we think is a particularly aggressive movement based task, but for him, his role in the team in that particular area of play is quite a leadership position. So it's quite, he needs to put a lot of thought into that. He might be involved in calling the line outs, but it's certainly something where he's a lot more involved. And I think it was actually that, once we kind of unpacked that a little bit, he sort of realized that he was having difficulty with processing some of the plans and some memory type things. And so it meant that he could go away with a bit of a shopping list of what to work on for that. Whereas it may be another athlete that you think, okay, the priority for this session is I'm just going to look at movement planes. I'm going to keep intensity the same so I know they can run steady state. It spike their symptoms, and we're just going to introduce some change in direction, and we're going to leave it at that. And we sort of layer it on that way rather than a whole lot at once. Because the nice thing then is if they have had an increase in symptoms, it's very easy to just pull it back one stage rather than them having to start all the way back to square one and build from there. So contact's always an interesting one. And obviously we need to be pretty confident that they have recovered before they're looking at, reintroducing contact given the risk of potential other injury. But there are ways you can break down contact. So if you think about what contact, if we think of a tackle, or in football, if you're having a clash against someone's shoulder in the air, or, and God, I played netball for years and it's certainly a contact sport. There's a lot of facets of that you can actually start to retrain before you put them into a higher risk situation. So things like preparation for impact or that sort of vibration sense. So it may be that they're doing jumping and landing. It may be that they're getting some bracing practice. So you can look at kind of boxing on a bag or something like that. And just having a little bit more of a think about how you can sort of do that in a more graduated manner rather than going from yay to 100%. Cool. And then our last one is, anyone who's worked at Concussion has seen this person a million times. So this is the very type A, highly strung, highly intelligent, highly stressful job, big expectations on themselves, wearing lots of hats. I mean, I have chosen a specific patient, but I probably could have picked about 20. And when you're looking at their symptom load, it's across the board. Everything's really, really challenging. But this woman in particular was quite a good historian. And her main issues when she was describing what was bothering her the most was this kind of mood disruption. So she was feeling really irritable. She had kids and she was snapping at the kids a lot. And she was finding that she wasn't able to kind of control her emotions. She was also feeling really up and down, crying a lot. And then she described some really key things. So she said, I feel like the world kind of closes in on me. Like I get this real sense of tunneling. And she described feeling really overwhelmed and overstimulated. We hear that a lot. She also said that she couldn't catch her breath. She just felt like she was constantly a little bit short of breath, and that wasn't feeling, like it normally would. She was really distractible. And this is someone who typically had very high levels of focus. Her job required some pretty full-on ability to kind of stick on one task and manage multiple tasks, but do all of them well. And she felt like she was kind of doing the opposite. She had a really marked issue with photosensitivity. She also described some weight loss, not to a point where it was, of anything of concern, but something that she'd noticed. And she was a fairly slim woman anyway, and she certainly wasn't doing anything to try and lose weight. And she had poor sleep quality. So I guess the key thing to think about with this case, that the reason I brought it up is it's this idea of sympathetic dominance that we see heaps with concussion. So she's stuck in that fight or flight mode. And there's some ways that we think of fight or flight that are relatively straightforward, but there's some other ones that sometimes we don't think about so much. Those of you out there with some breathing expertise could probably speak to some of those aspects a lot more intelligently than I could. But I sort of would sort of sum it up as people often don't feel like themselves as far as their sense of movement, their sense of themselves in their body. They feel a bit kind of uncoordinated or weird. They often describe things like difficulty going up and down stairs or depth perception or those kind of things. And the easiest way to imagine that rest and digest, or that parasympathetic state that we're kind of after, is that flow state that some of you may have experienced if you're athletic, or where things just work and it's easy and it's relaxed and And these people aren't experiencing that hardly at all. And so I guess I feel like my practice has changed a fair bit over the years, and that I don't think initially I used to respect this as much as I do now, but I think there are a lot of so-called physical interventions that we can give someone that give them a sense of autonomy and a plan and something to do, but that actually target this issue here. So we're trying to encourage parasympathetic activity. So, I mean, reassurance is a massive one, and I think that's where we have to be really, really, really careful with our language. The number of people I've spoken to, particularly long term with these type of injuries, who've heard one phrase and they've just held on to that, and that's become a really key part of their kind of injury identity. So it's making sure we're not nocivic with our language. We're encouraging them. They're going to recover. It might take time, but they will get there, that kind of thing. Balance training, I've got there, has to be appropriately prescribed. So someone told me I should have this embroidered on a cushion once, but I always tell my patients to find the wobble, not the step. So when you're doing balance training, it shouldn't be at a level where they feel like they've got to initiate a step strategy, or they're getting that kind of sense of, oh, I'm losing my balance. Actually, with this group of patients, if you're prescribing them balance training, your aim is for them to be aware of the sensations that their body is producing. So you're actually trying to get them to be aware of their postural sway, to be aware of the weight distribution through their feet, and those kind of grounding. You can tell I'm getting my yoga teacher. It's coming out of me a little bit with this. I'm trying to be less fruity so Forch doesn't give me grief. But it's for a different purpose than potentially balance retraining, where you think of a performance outcome. Okay, so this is where you might do your testing with them, and you might peel that level of difficulty back several steps to the point where they're actually not finding it particularly challenging, but you're giving it to them with a different purpose. Okay, the same thing applies there with a walking meditation. That's where you might look at like a tandem walk, that we give as quite a common exercise. But you might ask them to do that in a way that is very mindful, very slow, very aware of what they're doing. So I'll typically say, all right, I want you to try and walk along a line, but I want you to try and do it as slowly as you can. See if you can feel your foot being kind of peeled off the ground, and feel it come through and take the ground in front, those kind of things. So they're getting out of that sort of wind up fight or flight, and they're getting into their own sense of their body during movement. Breathing's really useful, completely. Like I said, there's people who are much better qualified than I am, but I think we can all talk to that simple breath strategy, slow down, be aware of how you're breathing. I would be a little reticent to change someone's breathing pattern, but even just slow down and close your eyes and feel yourself breathing. I think there's merit in that. There's also it's a yoga thing again called Brahmari breath, where you actually hum. So humming can get some vagal nerve activation, which is great. So people who are a bit open to that kind of thing, I'll sometimes get them to use that as a bit of a brain break recovery if they feel like their symptoms are getting a bit elevated. Go somewhere quiet, cover their hands over their eyes, and just do some little bit of humming. Any of that mindfulness, kind of guided meditation, sort of relaxation type stuff, appropriately done yoga. As someone who does practice yoga, it really frustrates me when people sort of have a negative experience with it. And this particular patient, I was like, look, here's something that you could try. Go and do a nice relaxing restorative yoga class. And she went to some massive big gym one where it was lots of quite aggressive flowy postures, and it was just a complete absolute balls up. She was not very impressed, and I was like, well, that's not what I was after. So as long as it's the right type of yoga. And then the kind of happy hormone stuff that sometimes we forget about a little bit. So these people, anything we can do that taps into those happy state, whether it's happy music, whether it's looking at pictures of things, good memories, bringing all of that stuff to their mind's eye, particularly when their symptoms are coming up, that can be really helpful. And then the other thing from a physical capacity that I like to give them, sometimes not because I feel like there's an actual issue with that that particular function, is peripheral vision exercises. Because if we think of the function, fight or flight, the sympathetic function, we do get this real tunneling. We get very locked in and focal. Think about you fighting a tiger, you're looking at the tiger, you're not worried about what's around you. So anytime we open up awareness of that space, it's actually a parasympathetic function. So giving someone some really simple peripheral vision exercises can have twofold effect. A, it might help their peripheral vision, but B, it might be quite a nice cue for them to sort of get out of that state. And that's actually used in things, sort of anxiety training and stuff like that too. And I think there's an interesting role for it in sports as well. So if you've ever had one of your athletes go red, I've seen this a million times on the sideline where the red mist has descended and they're just making stupid decisions and they're all over the place and something's rattled them. It could be that you give them something physical, like, they're in a huddle. What can you see next to you? Are you aware of your teammates on either side of you? That kind of thing can help snap them out of it a wee bit. And this is one of my favorite comics by Michael Lunig. So what is worth doing and what is worth having? It is worth doing nothing and having a rest. You must rest, otherwise you'll become restless.
That's a very deep way to finish there, Katherine.
Had to get a little bit deep for you, Forch.
Yeah, that's good. Hey, so there's a couple of good questions here that have come in. I haven't forgotten about the poll. I'll get that in a sec. But there's one around with someone that maybe there's a suspicion around, have they got some vestibular impairment? When would a therapist consider referring to someone with a subspecialty interest in vestibular physio?
So I think if they've got if you use VOMS, so that's a tool that's been designed for people without vestibular expertise. But if there's some findings that are significant on the VOMS, then I would be getting that ball rolling relatively quickly. If it's someone who's outside kind of 10 to 14 days of their injury. Within that period of time, there is a fair amount of people that do spontaneously recover. So if it was past that 2-week mark and there was some relatively significant things that you feel like were contributing to their symptom load, then I would be getting someone on board and getting them looked at. And personally, I love having someone come in for a one-off and then I can say, right, go back to your physio. Your physio is awesome. They're doing wonderful stuff. Here's some ideas of things you could tweak. And it can be a collaborative approach. It doesn't necessarily have to be you kind of handing them over.
Cool. If we just go back to that first case you're talking about, the guy with a 3-year history of being off work and whatnot, and how some of the treatments that you said improved his pain or he felt like he was better. How do you find that those types of treatments, how lasting is that effect? And so what's your sort of strategy to build on that and make a lasting improvement?
Well, it's interesting because I feel like the improvements that you typically get in the clinic, I think, are supplemented by what they do at home. But if they're coming to see you in the clinic, most of them don't do the stuff you give them at home because they're like, oh, I'm just going to come and see you and you're going to make me feel better. And so that guy was challenging from a buy-in point of view because he was quite irritable regarding his neck. But once he'd seen that link, I think that helped him realize the importance of doing some of these things regularly. I don't think he's going to be a miracle quick fix. Like, he's still got a long way to go. Don't get me wrong. There's a lot to unpack with that. But I think that, yeah.
It's maybe about giving a little bit of hope that he can.
Yeah, exactly right. Exactly right. It'd be had to have someone come in and say, look, don't know, can't really find anything. Good luck. Yeah.
Okay, and so with you're talking about the rugby case about training, preparing for contact and doing that in bunch-like pieces or little bites. So Anya's got a good question here about how do you retrain or improve the cognitive demands of a rugby player?
Yeah, and that's really tricky. And as far as I'm aware, the research is that as far as cognitive retraining, there was the Brain HQ team did a study looking at It's like an app where you do brain sort of cognitive retraining. And I think they had about a 50%, I'm hopefully not butchering their research because I don't know if I've seen it published, but I have heard anecdotally it was about 50% of people had a benefit from using something like that, as far as it decreasing their return to playtime and things like that. I would say I look at it in two ways. If there's something else going on that you feel like is using up brain fuel, for want of a better word, and that's why their cognitive deficits are there, then you've got to address that cause, because that's probably the real crux of the issue. And a cognitive load on top of that is just taxing an already taxed brain. But if you've got someone and they've got relatively good function in those other areas, but it's really just this cognitive deficit, then look, if it was me, I would give these things a go. But the research isn't there to say this approach over that approach is going to be better.
Yeah, and I think that's kind of what we're doing every time we treat with someone with concussion, aren't we? So we're trying to create an environment where they're able to do as much as they're able without blowing up, supporting and encouraging cognitive recovery by not killing themselves with too much activity. So there are those specific cognitive retraining tools, but actually the entire nature or the recovery plan for most people's concussion does help that a little bit too. Anyway, I'll stop talking. It's your gig. Do you find the need to work on swallowing retraining hyoid work, say if bracing the hyoids for segmental flexors? I have to say I don't even know what that means.
Was that Karen? I haven't even looked. I bet was that
It
Karen
was.
Regan? Karen's much more of a guru with that sort of what would be driving that. Personally, if I get someone who I'm trying to do deep neck flexor training with, and they describe some of those symptoms that I think all of those things that you just mentioned are probably involved, I cue them to try and switch off. So either press their tongue hard into the roof of their mouth while they're doing their deep neck flexor retraining. So if you do that, you kind of inhibit some of those muscles. Or I would think that I hadn't prescribed the exercise appropriately and that they can't do it at that level. So we've got to scale it back a bit. So that guy, I would get him doing it in supine to take gravity out of the equation.
Cool. And I think maybe the last question for the night, so it's a good one as well, around when you're talking to people about vestibular training, have you got any suggestions about good resources or places to go to find materials that you might help support you?
Yeah, the VEDA, the vestibular disorders, I think it's just veda.org, is really good. They've got some really good patient level information on there. And that's probably the, I guess, one-stop shop that I would suggest. I do send people in some, particularly now with Telehealth, direction of some YouTube links, but you've got to curate it a bit because there's a lot of rubbish out there. The Physio Tutors channel has some pretty good vestibular information on it.
Cool. Hey, well, guys, thanks very much for that. I'm sure that if there are any more questions, if you send them in on email or put them on Facebook, we can get an answer out to you. And thanks, Dane, for answering some of those questions. I saw you typing away. How many screens have you got, by the way? You look like you were sort of looking everywhere. It was ridiculous.
I got like 2 big ones. Lots of cutting and pasting.
Yeah, I bet. And then this poll, the poll's quite interesting. I think that should pop up in your screens, but it looks like, I'm sure most of you know that there's been some changing the way the regulations around allied health have been framed and what maybe you're able to do at level 3 and the way we think about that. So it looks like the majority of people out there are thinking about not seeing patients at level 3, 72%, and then there's 14% each not sure yet and planning to see some patients. So for those of you that think you might see patients, we did share, I think last time out, our SOP for level 3. So if anyone wants to have a look at that, it's just, there's nothing special about it, but it sets out some guidelines around when we can see patients, how we're going to see patients. We will be starting to bring more patients in at level 3. So we'll be running some injection clinics. We'll be getting people in for, assessing neurological exams and things like that, because frankly, we kind of need to, and the patients need it. So if we can help with any kind of information like that, don't feel shy about reaching out. We've got some of those things that we can share. And otherwise, thank you to you guys. Thanks, Dane, and thanks, Katherine, and thanks to all the good questions out there, particularly the one about the hyoid. And I loved it how you absolutely picked who it was without even knowing about it. I didn't even know we had a hyoid specialist in Auckland. So
Yep.
Yeah.
Karen's a specialist in all sorts of things.
Yeah, okay. So I know where to go now with that. So I guess also, given that we're hopefully going to be at level 3, and it probably means that most of us still at home, we're planning on doing another couple of webinars, and so we've had some great suggestions about those. So I'll try and get a little bit more information about what they might be about out tomorrow. And hopefully this was a good one. I thought it was. I was particularly horrified about beer drinking and cheese and calories and stuff. I've been furiously Googling what a 1,500 calorie diet looks like. And
the only thing I heard from that was that you could be more moderate with women. So I just thought I could eat what I like.
Also something about, as long as you eat it early, you should be sweet. So anyway, so there's a few key take homes from you and me that possibly reflect why patients don't do dumb stuff. They only hear what they want to. Anyway, I'll stop blithering. Lovely to see you all, and we'll aim to catch up next week, same time. Thanks, guys.
Keep down, everyone.
Thank you.
Bye.
See ya.